Bicuspid aortic valves are more prone to leaking because of that abnormal structure.
So many things can go wrong. What about dilation of the aortic root? What causes that?
High blood pressure is a common cause.
Okay.
Also, Marfan syndrome, a connective tissue disorder that weakens the walls of the aorta.
Right.
And syphilis, a bacterial infection that can damage the aorta.
So many different causes.
There are.
Yeah.
So that support structure for the valve is weakened or stretched, and it can't close properly.
Right. And we also see aortic regurgitation in cases of trauma, dissection of the aorta, and certain inflammatory conditions like Takayasu's arteritis.
Exactly. It's incredible how many different things can lead to a leaky aortic valve.
It is. And thankfully, we have echocardiography, which allows us to visualize the valve in the aorta to help us figure out the cause.
Exactly. Now, you mentioned earlier the heart's really good at compensating for problems.
Yes.
How does it adapt to aortic regurgitation? Well, the heart's main way of coping with aortic regurgitation is to enlarge that left ventricle.
Okay.
As blood leaks back into the ventricle, it needs to accommodate that extra volume. It's like a balloon expanding to hold more air.
So making more space.
Yes. This enlargement allows the ventricle to maintain a relatively normal ejection fraction, which means it's still pumping out a good percentage of the blood it contains.
Right.
Even though it's getting more than usual.
So working harder, but still managing.
Yeah.
But are there any long-term consequences to this?
Unfortunately, over time, this chronic volume overload can damage the heart muscle.
Oh, no.
As the ventricle stretches, it has to work harder to generate the same amount of force.
Oh.
It's like stretching a rubber band too far.
Right.
Eventually, it loses its elasticity and snaps.
Wow. So it's working harder, but getting weaker.
Exactly. What happens then? Eventually, this can lead to left ventricular dysfunction.
Right.
The ventricle can't pump as effectively.
Okay.
And the regurgitation can worsen. It's a vicious cycle.
So catching it early is key.
Absolutely. Now, how do the symptoms and signs of aortic regurgitation differ from aortic stenosis?
Right.
What do doctors look for?
Yeah, that's a good question.
Well, the presentation of aortic regurgitation can vary greatly depending on how severe it is, how quickly it developed, and the individual patient.
Of course.
Some patients might not have any symptoms for years, while others may develop symptoms early on.
So it can be silent?
It can. Unfortunately, sometimes by the time symptoms appear, the regurgitation is already severe.
Oh, wow.
And the heart is struggling to function.
That's scary. What symptoms might patients experience?
Well, fatigue is common.
Okay.
As well as shortness of breath and palpitations.
Makes sense.
The fatigue is because of decreased cardiac output. The body isn't getting enough oxygen-rich blood.
So it's not delivering.
Exactly. What about the shortness of breath? That's caused by the blood backing up into the left atrium and lungs, leading to congestion and fluid buildup.
So similar to mitral stenosis, just a different valve.
Exactly. And those palpitations, the awareness of the heartbeat, are often due to the forceful contractions of that enlarged left ventricle.
Okay.
Some patients also experience angina, especially at night or during exertion.
Interesting.
Yeah.
Why would someone with aortic regurgitation experience angina?
There are a few reasons.
Okay.
The enlarged left ventricle demands more oxygen.
Right.
But it might not get enough.
Okay.
Also, the diastolic blood pressure in the aorta can be lower, reducing blood flow to the coronary arteries that supply the heart muscle itself.
Right.
And as we talked about before, some patients might have underlying coronary artery disease.
Okay, so a lot to contend with.
It is. What about the physical exam? What clues point to aortic regurgitation?
I'm listening.
A key finding is a wide pulse pressure.
Okay.
The difference between the systolic and diastolic blood pressures?
Right.
In aortic regurgitation, the systolic pressure is often high because of that large volume of blood being pumped out.
Okay.
But the diastolic pressure is low because of the leak.
So high peak, low valley.
That's a great way to put it. We can detect this wide pulse pressure by measuring the blood pressure and by feeling the pulses.
Okay.
Aortic regurgitation also has several peripheral signs related to that larger stroke volume.
Okay.
The amount of blood ejected with each heartbeat.
Got it.
And that rapid runoff of blood from the aorta.
So the blood is really surging.
It is. And this can lead to some noticeable signs. For example, the Corrigan pulse.
Okay.
Also known as a water hammer pulse.
Water hammer pulse.
It's a bounding, forceful pulse that collapses quickly because of that blood flowing back into the ventricle.
Like a wave crashing and receding.
Exactly. What other signs might be present? We have de Rosier's sign, which is a murmur heard over the femoral artery in the leg when it's compressed.
Interesting.
and Hill's sign, where the systolic blood pressure is higher in the leg than in the arm.
So the force is more noticeable in the legs.
Right. We might even see visible signs like head bobbing with each heartbeat. And we can sometimes see the blanching and flushing of the fingernails with each heartbeat, called capillary pulsations.
So many different signs. What about the heart itself?
The apical impulse is often shifted downward and to the left. Because of that enlarged ventricle, we might also feel a systolic thrill over the area of the chest overlying the heart.
So the heart's taking up more space.
Exactly.
Yeah.
Listening to the heart sounds is also key.
Of course.
The first heart sound, S1, might be soft or normal.
Got it.
The second heart sound, S2, may be split. And you might hear an S3, that low-pitched sound indicating rapid ventricular filling. And then there's the murmur.
The defining feature.
It is. So the murmur of aortic regurgitation is a high-pitched, blowing diastolic murmur. Heard best along the left sternal border.
Got it.
It usually starts right after the aortic valve closes. And its duration and intensity tell us how severe the regurgitation is.
So it's a whooshing after the second sound.
Exactly. And depending on which way that blood's flowing, it might radiate to the apex of the heart or to the right sternal border.
Now, I remember reading about the Austin Flint murmur.
Ah, yes. The Austin Flint murmur is interesting. It's a low-pitched, rumbling diastolic murmur heard at the apex of the heart. But it sounds like the murmur of mitral stenosis.
So confusing.
It can be.
Why does that happen?
Well, we think it's caused by that leaking blood from the aortic valve hitting the anterior mitral valve leaflet, creating a sort of functional mitral stenosis.
So it's creating a blockage.
That's a great way to think about it. And the presence of an Austin Flint murmur usually means the aortic regurgitation is severe.
Wow. So we've covered mitral stenosis, mitral regurgitation, aortic stenosis, and aortic regurgitation. But what happens if someone has more than one valve problem?
Multiple valve problems or multivalvular disease definitely adds another layer of complexity.
I bet.
The presence of one valve problem can affect the blood flow patterns of other valves. It can be tricky to figure out how severe each individual problem is.
It's like a puzzle where the pieces are moving.
That's a great way to put it.
Right.
So, for example, if someone has both mitral stenosis and aortic regurgitation, the mitral stenosis might make the aortic regurgitation seem less severe than it actually is.
Interesting.
This is because the mitral stenosis reduces the amount of blood flowing to the left ventricle, which in turn reduces the amount of blood leaking back through the aortic valve.
So one problem masks the other.
Exactly. Are there any other examples?
I'm sure.
Of course. Think about the opposite scenario. The aortic regurgitation can make the symptoms of mitral stenosis worse, even if the mitral valve isn't severely narrowed.
Interesting.
This happens because the aortic regurgitation makes the left ventricle work harder, which can worsen those symptoms of mitral stenosis.
So a domino effect.
Exactly. And this interplay makes it really hard to use the standard formulas and techniques we normally rely on to assess individual valve problems.
So it's more of an art than a science.
You could say that we need a thorough history, a detailed physical exam and careful interpretation of the echocardiogram to assess the severity of each valve problem accurately.
It's like detective work.
You're exactly right. And it often requires a team of experts, cardiologists, cardiac surgeons, and other specialists to develop a personalized treatment plan for each patient.
So teamwork is key.
Absolutely.
This has been an incredible deep dive into the world of valvular heart disease. I feel like I've learned so much.
It's been my pleasure exploring this fascinating topic with you.
And a huge thanks again to London Heartbeat's Z Academy for providing the amazing material for this deep dive.
They're a fantastic resource.
Remember to subscribe to London Heartbeat Z Academy on Facebook, Instagram, Spotify, and YouTube to keep your cardiology knowledge up to date.
Absolutely.
And don't miss out on any future discussions like this one.
You won't regret it.
Thanks for joining us on this deep dive into valvular heart disease. Until next time, keep those hearts healthy and those minds curious.